attendance, and I'll be presenting grand rounds today on transplant surgery, where we've been, where we are, and where we're going to be going. First off, we're going to start looking at why transplantation is such an important field. I know we get a pretty good experience with it over at Lady of Lourdes, but kind of give you more of a national perspective as to where we're at with that. We're going to go over the history of transplant surgery, which I find just very, very fascinating. Our current state of transplantation in terms of how organs get allocated and some of the issues that we run into with transplant surgery today. Some strategies for decreasing the need for transplant surgery, because as we'll see, we've got a huge gap between the people that need transplants and the availability of organs. Strategies for increasing donorship, which unfortunately has been pretty stagnant in the United States for some time, and also then at the end we'll look at some new directions that we're going to be going in transplant surgery in the future. So why do we care about transplant surgery? Almost 125,000 people are on wait lists in the United States right now, and over 100,000 people of those, of those people are on kidney transplants wait lists as of 2014. 25,000 people die in the United States from liver disease while awaiting transplantation. We look at the number of people that have renal failure in the United States, it's staggering, and we're approaching 500,000 people on dialysis. About 200,000 people in the United States currently have a functioning renal transplantation. As you can see, this is a way to get people off dialysis, but we still have a long way to go. From a monetary standpoint, we spend a lot of time, energy, and money on people that require liver transplantation, kidney transplantation, heart transplantation, things of that nature. Transplant is estimated to save about $10 billion a year annually in healthcare costs, or about $55,000 for each year of a functioning transplant. Take a look at some of the history here. The first real documentation of a successful transplant, which I'm a little bit skeptical about how truly successful it was, were two brothers, Cosmos and Damon, in the 3rd century A.D., who, while on a crusade, had a fellow crusader lose a leg, and they transplanted a native person who was from the area's leg onto him. They said this was successful. I have my doubts. But as you can see, as we move through the years, we get into cadaveric bone transplants, cornea transplants. It wasn't even until 1900 that we identified really ABO blood type. This actually resulted in a Nobel Prize. As we got into the turn of the century, we started dealing with vascular anastomoses, which is really a big step forward in transplant surgery and makes transplant surgery possible. Alexis Carrel, a gentleman from France, in 1902 published the operating technique for vascular anastomosis and organ transplantation. Interesting thing when looking into the history of Carrel, one of the things it seems that he was really, really good at was being a high-volume publisher, but also forgetting the names of the other people that were on the work. So, you know, he studied under Jabulet in France, who's a big name in vascular surgery as well, and eventually there was a falling out there as there was felt that due credit wasn't given. And then he went on to work with Dr. Charles Guthrie in the University of Chicago. That relationship only lasted a year as well, over concerns about proper authorship on papers. But he did an awful lot for transplant surgery regardless. He started working on cold preservation as early as 1910, and actually along with Charles Lindbergh, that guy that flew across the Atlantic, came up with a preservation and perfusion device in the early 1900s, and he won a Nobel Prize for his work in vascular surgery in 1912. Dr. Charles Guthrie out of the University of Chicago really did a lot of the advancement of the techniques for vascular surgery. And it wasn't that anastomoses hadn't been done previously. They had been done and published and were well known in the few years before that. But he started using finer needles, different suture materials, and really advanced the field as it was. Continuing on, as of 1906, Jabulet out in France actually put a swine pygmy into the arm of a 48-year-old female. Didn't last. Patient did succumb quite shortly thereafter. And what you'll see a lot of times in the early transplant, we weren't putting organs, kidneys, things like that where we're putting them now. Very often they're being put in the antecubital fossa. There's a lot of examples of these being anastomosis vessels in the neck, places where the organ could be observed. As of 1912, we now had heparin, which was an important advance in terms of stopping clotting and things like that. In the 1920s, we started to kind of recognize that there's a little bit more involvement of an immune process here. And they started actually using total body irradiation and splenectomies for folks, looking at making them viable candidates for possible bone transplantation and things of that nature. In 1936, there was a gentleman by the name of Vonoroy out in the Ukraine who really did the first human-to-human kidney transplants. All of his patients died, but interestingly, he did demonstrate patency of vessels up to 48 hours out of surgery. And his information and everything wasn't really known to the West until really the 1950s and later, as all these things were published essentially in Russian journals that we didn't necessarily have access to at that time. In World War II, Peter Medawar and Thomas Gibson did an awful lot of work with skin grafts, and this proved to be monumental in transplantation. Basically what they were doing, working on mice, were taking skin grafts from mouse A, putting them onto mouse B. And they found that if afterwards they did the same thing, where again they took mouse A and put a skin graft from mouse A into mouse B, the graft lasted only about half the length of time before it really started to look bad on a macroscopic level. On a microscopic level, it looked like cell-mediated hypersensitivity. So now we have evidence that there is an immune basis for rejection. And Peter Medawar went on to be really kind of a big name in immunology and transplantation in general as a result. He didn't really do a lot of work in cell-mediated immunology, but really focused on antibodies. He also looked at the idea of free martins. Now, these are fraternal cattle twins that in utero actually share blood and were found to, later on in life, exhibit blood and blood type and cells from the other twin, which really shouldn't be possible. So they started coming up with this idea of tolerance, where the body can, through whatever mechanisms, start to tolerate non-self cells. This is still a big idea in transplant surgery today. Nice quote from him. Nearly everyone who supposed that he was using transplantation to study tumors, and that's how a lot of this happened. They'd take tumor cell from subject A, put it on subject B, and see what happened. They're really studying cancer. Was in fact using tumors to study transplantation. Leo Loeb was a pathologist who did a lot of work with waltzing mice. He had a line of mice with a specific neurological deficit. And he was doing transplantations of tumors between these mice and wild-type mice. And doing this and looking at the F1, F2 generations and where rejection of these tumors occurred, he was actually able to demonstrate genetic differences between donors and recipients, prove Mendelian inheritance when it came down to transplantation, and also prove that there were multiple loci. These are the HLA types that we run into over at Lourdes nowadays. Also was very big in coming up with lymphocyte involvement and how that worked. Some of you may know him from his work with Graves' disease, more famously. So continuing on, in Boston in the mid-40s to early 50s, we're having quote-unquote successful renal transplants. Again, their definition of success is not exactly what it would be for us today. Many of these patients got off the OR table and succumbed within a few hours, but those are considered successful. There was one particular lady, however, who had acute kidney injury, had a deceased donor kidney placed in her antecubital fossa, actually started making urine, and the graft lasted for 4 days until she recovered her function and then was able to go home and live a normal life thereafter. In the 1950s, bone marrow transplant is a viable option after total body irradiation, really knocking out the immune system that way. And in 1951, the first instance of using the iliac fossa for a renal transplant site, which is really what we're doing now, occurred in France. The French were actually very big in transplant very early on. They even had a group of guys called the French Transplantation Club that were doing a lot of work and a lot of publishing. Didn't truly have any successes, but these were the first guys that said, I think between identical twins, where we don't have genetic variation, we can have some possibility of success here. So a lot of transplant surgeons started working in that direction for refining the technical skills that were going to be required for this. In 1951, we've got some more work done on tolerance, which is very important. And 1952, Dr. Gordon Murray, who was out of Toronto, a big name in transplant surgery as well, ended up putting a kidney into a 26-year-old female who subsequently lived for 21 years. The kidney didn't function for all of that time, but she never actually required removal of the kidney for any sort of pain or major rejection issue. And then in 1954, we actually have what most people consider to be the first successful kidney transplantation. The Herrick twins, Richard had chronic kidney disease, and Dr. Joseph Murray, who mentioned earlier, out of Boston, transplanted a kidney from one twin into Richard in his pelvis. Surgery time, 5.5 hours, 82 minutes of warm ischemic time. And Richard actually went on to live with this kidney functioning for about 8 years before he died of a myocardial infarction. And his brother that donated a kidney actually just died a couple years ago. So I just thought this was a fun picture there. I was surprised the kidney worked as everyone else was. Further on to the history, HLA types in the late 50s. And Dr. Murray, again, pops up. He does the first successful non-twin sibling transplant. This was done after sublethal total body irradiation, and this kidney actually functioned for about 20 years. As we go further, now we're starting to get into immunosuppressive drugs. Total body irradiation didn't have great success rates because a lot of patients were passing away from the irradiation, so they started coming up with a lot of other drugs that would knock down your immune system. Many of these drugs had actually been used for other things in the past. They were failed cancer drugs. They were drugs that were discovered while looking into the fungus and things like that. And then they would notice that they allowed grafts or tumors to live longer than they were supposed to. And then they'd be applied to transplantation. However, we weren't doing all that great. In 1963, there was a big meeting. Got most of the big names in transplantation together from the US, from France, from the UK. And they looked at all their results. And they found that 52% of renal allografts from related donors and 81% from unrelated cadaveric donors died immediately. Didn't really make it off the table. Less than 10% lived for greater than 3 months. Irradiation also didn't pose that many successes. There was a gentleman there by the name of Thomas Starzl, who was actually kind of, when you look at the invitation list, was kind of an afterthought, who had been working out of Denver at University of Colorado, who presented some of his data. He was using a new immunosuppressive protocol where he was using combinations of drugs. Also the idea of using pulse drugs to treat times in which he thought acute rejection was happening, and his numbers were better than anybody else in the room. 70% of his renal grafts were surviving at 1 year. He actually had more functioning renal grafts at that time than everybody else in that room combined had ever had. At first people were skeptical, but then they looked at his data, it held up, and this idea of dual therapy and combination therapy for immunosuppression was really born. At the time, in 1963, there were only 32 centers that were even attempting transplantation in the US. It ballooned to over 50 within 1 year. So Thomas Starzl, again, one of these big guys in transplantation, he worked, they say, his workload was 10 times greater than the average surgical resident. He did 2 years of his residency down in Miami, and there's actually case logs available where you can look at his numbers. He did about 600 more cases in his 2 years in Miami than I'm going to do during my entire residency. So this guy was just an animal. Combination immunotherapy, immunosuppression was a big thing that he did. He also started using anti-lymphocyte serum, the stuff that we use for induction nowadays. In 1967, he actually did the first successful liver transplantation in Denver, using this combination therapy, using cooling of the organs and veno-veno bypass. Chimerism, which we'll talk about in a little bit, was actually what he kind of felt was his biggest accomplishment and idea, and he continued being active in transplant on the research side until he passed away actually just last year. In his heyday, he was published every 7.3 days, and he was the most cited scientist in the field of clinical medicine. He was declared to be that in 1996. So continuing on, 64, microcytotoxicity assay. These are the same, this is the predecessor of all the screening that we're doing now in terms of reducing and limiting hyperacute rejection has occurred. In 1968, Harvard actually convened a group to put together and to try to define what brain death was. Once they came up with those rules, then we started being able to procure organs from individuals that were brain dead, which obviously was better for the survival of the organ because it was continuing to have perfusion for a longer period of time. 1976, cyclosporin comes out. Liver survival at 1 year immediately jumps to 70% and 90 to 95% 1 year survival of kidney grafts. When you look at it, it's actually not that far off from where we are right now. We also started having groups of hospitals get together for the sharing of organs and matching up recipients and donors, which eventually would spawn the United Network for Organ Sharing, or UNOS, which is the organization that is in place today that deals with this. 1984, recognizing how important transplant surgery is and transplantation is, the National Organ Transplant Act is passed. The Organ Procurement and Transplant Network is established, and this is still in place today, and is how one of our most important tools for distributing organs. And as you can see, our immunosuppression therapy has continued to get better. Our cold our cold preservation solutions, such as UW solution, are continuing to get better. And in 1992, as we mentioned earlier, Starzl talks about chimerism. And he actually looked at all of his renal transplants going back through his history. He actually was able to identify 30 recipients who had a functioning kidney for greater than 30 years, but now weren't taking any immunosuppressives whatsoever. Why did this work? Why was the body not rejecting the kidney? And we're not exactly, to this day, really sure. There's many proposed processes for this. But something else that was interesting he found is he actually found donor tissue in other tissues away from the transplanted organ in the recipient, meaning that as a whole, the recipient was accepting the donor tissue as self, or at least wasn't attacking it. And this kind of so remains one of the holy grails of transplant surgery and how we can actually go about doing that. Overall, 5 Nobel Prizes have been awarded in transplant, and 19 in total if you include immunology. So this has really been a big field in terms of advancing medicine in general. So what are we doing today? Currently, 1 year function of renal grafts is expected to be 95%. For live kidneys, average between 12 and 20 years of function. For deceased donor kidneys, 8 to 12 years. So clearly there is a difference there. There is an increase in life expectancy, but this is much, much more pronounced in people that receive kidneys prior to dialysis, 10 to 15 years, versus only about 4 years for people that receive after dialysis. So I think this is something that in the future we're going to be focusing on, trying to get people transplanted before they have to go on dialysis. Regarding liver, 90% survival at 1 year. We do about 6,000 liver transplants in the United States yearly, and the 3-year survival is 70 to 75%. On average, liver transplant patients survive about 20 years, which works out to approximately 7 years less than the general population, looking at their age. We talked about the Organ Procurement and Transplantation Network, which works for obtaining organs and distributing them appropriately. The Scientific Registry of Transplant Recipients is a database that all transplant centers have to give information to that looks at outcomes at different intervals, looks at all the data in terms of who's getting kidneys. A lot of racial disparities are identified through this, age of transplants, things of that nature. So it's a really great resource for continuing research. The Centers for Medicare and Medicaid Services are actually the folks that approve transplant centers, and they do require this data reporting. So that's kind of how our infrastructure is set up right now. There are OPTN regions. There are 11 regions in the United States, and these are set up for the purpose of obtaining and distributing the organs as is in best practice at this time. We're currently actually in Region 2. There has been some discussion about changing how the regions are divided, but that hasn't happened yet. There were greater than 33,000 total transplants in 2016. And to give you a perspective as to how much we're actually growing and people that need transplants, one person is added every 10 minutes to a list, and 22 people die daily waiting for a transplant. That doesn't look into the people that are removed from transplant lists because they're no longer healthy enough to receive the transplantation. And consistently for greater than the past 10 years, less than 20,000 donors have been identified, and that number hasn't really moved. It's been quite static throughout. Looking at the cost of transplants, we talked about how much money transplants can save, but how much does a transplant cost in the first year after transplantation? You can see a heart costs $1.2 million, liver, which we obviously have more experience with, $735,000, and a kidney $330,000. So it's not a small undertaking. We're over at Lady of Lords. You hear a kidneys coming in. How did it get to you? So how are kidneys allocated currently? In 2014, some new guidelines went into place. They determined, after about 10 years of research, that the highest waitlist mortality is not necessarily the best use of that organ in terms of how long that organ is going to last. They did note that there were some definite racial disparities as well as some regional disparities in terms of who was waiting longer for kidneys. And the idea of utility versus equity. We all want to be fair with distribution of organs, but what is the best way to actually get the longest survival rate and the longest functioning organ out of it? These two are not always on the same page. Overall, they found that there was about 10,000 years of post-transplant survival that had been sacrificed over that 10-year period for the idea of higher access. Your average kidney wait time right now is about 5 years, but it is different for different blood types. Blood type O kidneys wait about 7 years right now. So there's certainly a lot of room to grow there. As you can imagine, most of these patients are on dialysis by the time they get their transplant. And this is just a little chart that I found that looked at how many people are getting transplants at what time. As you can see, 5 years or more, there's a lot of people on that list. Really, even in this 1 to 2 years is our greatest period of time where we have a lot of people on the lists at that time. But as you can imagine, those people are probably already on dialysis as well. So again, if the goal is to get the best function out of a kidney, it's to get it done before they get on dialysis. There are many ways that we're trying to increase donorship and who can receive kidneys. The idea of ABO incompatibility and doing transplants across blood types is something that we are doing now. Kidney tends to not tolerate this as much as liver and other organs. They're not sure as to the mechanism of this. It may have to do with the vascularity of the kidney and the microvascular nature of that. But I found a study that was done in Europe looking at the idea of using plasmapheresis to knock out the ABO antibodies in recipients. Looked at over 1,400 live donor kidneys that were not ABO compatible. What they found is in your immediate postoperative period, these people did worse. They actually had a higher mortality rate, thought to be mostly due to infection because they were on stronger immunosuppressants. But that after you got by that bump and that mortality increase, at 3 years there was no difference in the outcomes. Liver allocation, how are we doing this now? We're all familiar with the MELD score. I won't go into that too awfully much, just that it was originally developed for TIPS, for patients that might be candidates for TIPS, but it was found to be a better predictor of survival in liver patients. In 2002, it was adopted as really our main listing device for liver allocation. About 33% of our liver transplants now are done for hepatitis C, cholestatic diseases, 14%, alcoholic liver disease, 12%, and NASH, about 9%. But as we'll talk about, these numbers are going to be changing and changing quickly. Also keeping in mind that liver survival is not the same across the board. Patients that are transplanted for malignancy, HCC, things like that, have a lower 5-year survival rate than, say, patients that were transplanted for biliary atresia or some of our cholestatic diseases. So, over here on table 2 is kind of the breakdown of how livers are allocated right now. Status 1A, we hear this. These are people that have had a liver transplant that failed in the immediate post-op period. These are people that have acetaminophen toxicity or other types of fulminant hepatic failure. They go to the top of the list. They get the liver that comes out first. But then where do you go from there? Traditionally, we have awarded exception points to certain disease processes that have found to have greater mortality on wait lists than would have been predicted by the MELD score, but that's changing somewhat as well. The biggest thing that has happened recently in allocation has been the Share 35 initiative, which went into effect in 2015, where essentially all recipients, potential recipients in a region that have a MELD score of greater than 35 immediately go to the top of the list. So it led to livers being shared over a wider area, whereas a liver may have in the past stayed more locally and say gone into a patient that had a MELD of 25. Now it might be going regionally and further away for somebody that has a MELD greater than 35. As those patients are certainly sicker. And what we've seen as a result of this is lowered waitlist mortality in patients that have MELDs greater than 30 by about 30%. But we've seen some other results of this as well. Obviously, we're seeing a higher overall MELD average for patients that are being transplanted. They're sicker when they're getting the livers. We're seeing increased ICU time. We're seeing increased vent time. We're seeing increased cost overall. We're also seeing some livers that have an increased donor risk index. This is a way of looking at what is the expected quality of that liver and survival time of that particular graft. We've noticed that we're using essentially worse and worse grafts to make sure that we're getting these folks that have very high MELD scores livers. Overall, we haven't really seen a change in survival on the whole. We have seen a change in the sickest patients. And it is felt that it has reduced some geographical disparities. So looking at some of the disease processes and how we can maybe limit liver transplantation necessity in the future, hepatitis C, very large disease in the United States. Between 3 and 5 million people have it. About 20% of people that develop chronic hepatitis C go on to develop hepatocellular carcinoma or decompensated cirrhosis of the liver, both of which would can require transplantation. Unfortunately, if hepatitis C isn't completely eradicated prior to transplantation, those patients don't do nearly as well. The transplanted liver progresses to cirrhosis much more quickly than would have been otherwise expected, and at 5 years, up to 25% of these people have decompensated liver disease, and they're back in the same boat and need another transplantation. Thankfully, we've come up with some amazing new drugs. We've all heard in the news about Harvoni and some other related drugs that promise a cure rate of greater than 90% for some serotypes of hepatitis C. This is big news, and it's a great thing for these patients. The problem is the cost. The cost of some of these meds is $1,000 a pill. The cost for a full regimen of Harvoni, as it stands, is almost $100,000. They're playing around with doing shorter treatment durations, but right now it's about a 12-week treatment protocol. They're looking at an 8-week treatment protocol to reduce costs. To put that in perspective, if you're going to treat all the hepatitis C in the United States, it's about $250 billion in medications to do that. In 2011, the total drug cost for all diseases in the United States was about $263 billion. It's an awful lot of money. The pill itself costs about $3 to make. So there's been a lot of ethical discussion, and it's even reached the congressional level, looking at why this is, and is this the way this should be? Should the government be getting involved in setting prices on this? And why the price is so high to begin with. Is it development? Is it marketing? What's the issue? We're still not there in solving these issues, but these are things that we're going to have to be dealing with extensively in the future. Hepatocellular carcinoma. This is one of those disease processes that had gotten what is called MELD exception points in the past, and still does. These are people that, based on their MELD score, do worse than other people with the same MELD score. A MELD score of 25 with HCC has a much higher mortality than a MELD score of 25 from, say, alcoholic liver disease. This is moving just a little bit. As of 2015, HCC is now going to be listed at its native MELD for about 6 months, and then it's going to be given a MELD score of 28 immediately, regardless what the MELD is after that. And then every 3 months that the person remains on the list, they'll continue to get extra points up to a max of 34. The idea here is let's recognize that these patients don't do as well, but with HCC, they're certainly not as sick as the folks that have MELDs in the 35 range and above. So this is one of the things we've been doing recently to kind of work on the equality and the equity of distributing organs. And this is just a list of some of the MELD exceptions that we talked about earlier. There's some genetic diseases in here as well. So NASH, this is something that is going to be big. Non-alcoholic steatohepatitis. About 2/3 of the obese population in the United States has some level of fatty infiltration of their liver. About 20% of those people actually go on to have steatohepatitis. It's thought that NASH is going to become the number 2 cause of liver transplantation in the near future. If you look at the time frame from 2004 to 2013, the number of people listed for liver transplantation because of NASH has increased by 170% as compared to people for alcoholic liver disease at 45% and hepatitis C at 14%. Interestingly, NASH patients tend to have a much higher waitlist mortality than either alcoholic or hepatitis C patients for listing. They generally have a lot of other health problems as well, so that does make some sense. So how do we find, identify, get more organs to make up this shortfall of people that do require transplantation and haven't? The idea of extended donor criteria. When transplantation was really taking off, of course, you want the youngest, best, healthiest organ. But do people that don't fit these criteria really provide organs that do any worse? So they've looked at older age, people that are overweight, hypertension, things of that nature, to see do the organs actually perform worse once they've been transplanted. And they've shown that donors can be up to 70 years of age, and this should not preclude them from being donors. Obese patients is fine to use for donation. Vascular anomalies, and by this we mean multiple vessels, things like that, so long as the surgeon feels that they have the technical skills to take care of that, shouldn't be an issue. I think we've all heard Dr. Youssef talk about putting together multiple arteries and things like that. For him, that's something he feels confident doing, and he can use these organs. Still don't want to use, say, a kidney from somebody with hypertension because they're at greater risk of developing kidney disease later on. And they talked about using organs from minors, and this is something that's actually been floated out as well in terms of encouraging people to do live donation. Things like giving tuition reimbursements, they still would not recommend using organs from minors. So how about donation after cardiac death? Most of the organs that we end up seeing are folks that have been declared brain dead. But not everybody fits in that category, and there's a large number of people that we are starting to use that are actually patients that are deceased by a cardiac definition, meaning that the heart is stopped. Generally how this occurs is you have somebody that for whatever reason is requiring life support. The family has made the decision to donate. The patient is removed from life support, and you watch for how their vital signs go. And once they have ceased to have electrical activity, you wait another 5 minutes to make sure nothing comes back, and then generally speaking, the procurement procedure is begun. As you can imagine, this isn't great for the transplanted organ. All that period of time is warm ischemic time, which leads to greater injury. And additionally, when you have poor perfusion, say you have somebody who's got a blood pressure of 40 over 20 for a half hour, that also leads to a lot of tissue damage. So can we really use people in this situation for donation? Regarding liver transplantation, we found that there's more primary non-function, there's more anastomotic and biliary strictures, and overall there are worse results. That being said, the mortality on these patients after transplantation is better than if they'd remained on the list, so there's still a lot of work to do there. Regarding kidneys, we see a lot more delayed graft function where the kidney isn't making urine for some time, but that's generally recoverable. And overall, these patients have shown the exact same results as the extended donor criteria patients that we just talked about beforehand. Really briefly on ischemia and preservation, this is basic science stuff that we've all gone through before, but when you're no longer having flow to an organ, you start having tissue death. And subsequent restoration of flow with acute reperfusion injury is a major problem that we see, because obviously, anytime you've had an organ that's not being perfused for some time, you can end up distributing toxins, potassium, things like that to the recipient, who, as you can imagine, is not the healthiest patient to begin with. So why organ preservation? 19 times less glucose, more glucose is needed to make ATP for metabolism when a cell is in anaerobic mode. And hypothermia is found to really limit this. Metabolic rate's about half normal at 10 degrees Celsius and less than 10% at 4 degrees Celsius. So really quickly cooling organs is a methodology we've been using to try to preserve tissue. Many different solutions have been used for this. The most common one used now is UW solution, University of Wisconsin solution. Very high in K, mimics intracellular composition to try to stop the flow of ions and try to maintain cellular stability and membrane impermeability. But there are a couple problems. First off, it's pretty viscous. You guys that have been on procurements and things like that, it's really kind of a thick substance. So it may not do the best job getting into microvasculature, which is maybe why we see some issues with that. It's more expensive than some of the other fluids that are out there, and there is some worry about hyperkalemic arrest being caused in the recipient when you restore flow. Interesting, clinical trials have not really shown a ton of differences between any of these solutions. Where the differences have been noted have been in the scientific registry information that's been collected. But overall, it appears that UW solution should be used for organs that are going to be having longer ischemic times, whereas some of the other solutions, which may be less expensive or have less effects on the recipient, can be used if the anticipated cold time is going to be shorter. And this is just a couple of our times that we look at for how long we can use organs. Quite frankly, I know we go out quite a bit longer on our kidneys than this 18 hours. Where are we going for preservation? Well, the idea is to keep on having the organ be perfused throughout. So there are some devices and strategies that have been involved for normothermic perfusion of deceased donor or deceased by cardiac death patients by using bypass and ECMO. There's also been some cold mechanical perfusion devices that have been developed where actually instead of just flushing your couple of liters of UW solution through the organs, you actually have a pump that continually pumps this through. There's also some normothermic mechanical perfusion devices that have been come up with at this time. Some are being used. They're certainly not widely used at this time, but this may allow us to extend the period of time that an organ is still a viable option going forward. And actually, I found this interesting paper that looked at a liver hypothermic preservation pump. And really, what they're looking at is, we're throwing away a fair number of livers for whatever reason. About 10% of recovered livers are discarded. If we can preserve them better, would we be able to use these? This paper actually looked at specifically what they called orphaned livers, meaning they had a recipient lined up. For whatever reason, that recipient fell through at the last minute. Now you've got an organ and you're scrambling around for a recipient and time is ticking. And people are saying, no, we don't want to use that organ. Would using some other form of preservation or mechanical preservation by pump be able to help with that? And they think that, yeah, that's a direction we can go. They showed that there were fewer biliary complications and shorter hospital stays in people that had a liver transplanted to them that was on this pump versus people that did not. How else to increase donorship? The idea of a swap of organs. We've done a couple over these at Lady of Lourdes where you have, say, spouse A and husband A and husband B, husband A and wife A, and husband B and wife B, who aren't matches for their spouse, but they are a match for the other individual. This can be arranged where a swap of organs occurs. Something else that's been done is the idea of paying it forward and exchanges in which one person may not be a match for their spouse, their friend, their loved one, but they're willing to donate an organ. So there's a lot of centers, UAB is the one that put this study out, who said, okay, let's donate that organ, and then we're really going to work to get your loved one towards the top of the list. And there have been ways that they've been moved up the list. And then when an organ becomes available, they are getting that organ. There's actually a chain that was started at UAB in 2013 doing this. And the paper that is published here got out to 28 renal transplants and was still going. I actually talked to these guys about it. They got out to about 120 transplants before the chain got broken. It's hard to say how many of those transplants would not have occurred had this not been going on, but I think it's a nice way of increasing donorship. Live liver donation. This is something that's not done in the United States extensively. As you can imagine, the donor hepatectomy is a morbid procedure. You can have bad outcomes, and a lot of places are not doing this. If you were to, God forbid, have a mortality on a live donor, that's essentially a program ender. It can be a very, very bad thing for your program, so people are staying away from it. However, in Asia, due to religious beliefs and some other issues, almost all liver transplantation is done by live donors. There's actually a hospital in Seoul, South Korea, that is doing about 200 of these a year, and the people that are doing them in the United States are going over there for 6 months, essentially, and observing and participating and learning how to do it because they have so much skill in doing it because they're doing such volume. And that certainly is an avenue in the future that we may be able to use to increase donorship. Financial concerns, financial impediments or incentives for donation. Currently, travel alone for somebody that's going to be donating a live kidney is about $3,000 between travel back and forth from the center for workups, actual transplantation, things like that. So there have been some programs that have been put into place to cover this windfall. And in actuality, about 50% of people that have applied for these funds have actually gone on to donate. So it seems like it's been reasonably successful. But whenever you start talking about incentivizing monetarily transplantation, there is an issue with the ethics of it and this idea of human organ trafficking, which we've all heard the urban legends, but it certainly does exist. So there actually are programs out there now that are working on identifying individuals that are doing what is called transplant tourism, where if I needed a kidney, I'm going to go to a different country specifically for the purpose of obtaining a kidney, in terms of not knowing their doctors, traveling with people they don't know, asking for medical records to be sent to an odd place, things like that. But overall, it is an issue, and the BBC actually had an article just last week looking at this regarding Syrian refugees and the significant increase they've seen in organ trafficking involving them and other marginalized groups. So this is unfortunately a real thing. Would compensation of organs reduce this black market and transplant tourism? Right now, about 10% of all globally transplanted kidneys are thought to come from organ sale. Would the sale of organs actually benefit or exploit disadvantaged people that have economic hardships? This is a point that ethicists have argued for some time. How does informed consent apply? If you have somebody that needs funds to feed their family, is selling an organ a decision that they're really making without undue duress? So these are some difficult questions that are going to be answered hopefully in the future. Iran actually has come up with an interesting way of addressing this issue. They had a very large population on dialysis and a very large kidney waiting list until they enacted this Iranian Patients Kidney Foundation in 1999. What this did was it actually identified recipients, people that needed a kidney, and donors, people that were willing to donate a live kidney. They would set up a meeting with the government acting as an intermediary, in which the two parties would get together and an agreement from one party to the other would be determined. The government would be functioning as a middleman. The government also had a special charity set up so that the donor would get 1 year of covered health care along with some other financial incentives which aren't clearly defined in any information I could find to continue on with the donation. And then all of these transplants are performed at a state university hospital so that they can monitor and get good information as to what's going on. What they found is their list has been eradicated. There's nobody on the wait list any longer in Iran. The number of people willing to donate has been very high, so the price of the kidney itself overall has gone down. So what they've seen as well is that just because you are of lower socioeconomic class doesn't mean that you don't get a kidney transplant through this program. And there are some charities that have been set up to help with that. How do you stop abuse from happening with this, as it seems like it really could? They don't allow anybody that's not Iranian to be involved in this, so there's no tourism allowed. But overall, we're seeing about 84% of all donations coming from the lower class. So are we still really taking advantage of economically deprived individuals? What about other incentives? There was a study done out of Saudi Arabia, 7-year program, where they went and they talked to patients that were looking at deceased, the families of patients that were looking at deceased donorship. And they found that they were much more willing to donate if things such as funeral costs and hospital costs were covered. And they actually saw a threefold increase in deceased donors if only those things were added. What about the financial disincentives? We talked about it can be very expensive to be a donor. In 1984, the National Organ Transplant Act that we talked about earlier actually banned the buying and selling of organs. But what about making sure that people aren't actually paying to donate organs? And there's been many ways this has been discussed, be it retirement funds for the donor, tuition vouchers for younger people, income tax breaks, life insurance. What about covering the cost of ICU or hospital care for deceased donors' families so they don't share that burden? These are all things that have been talked about, but quite frankly haven't really been looked at in the United States because it's very difficult to trial efficacy when we have specific rules against this and they're interpreted. Giving financial means to people so that they aren't paying money out of pocket has traditionally been interpreted as financial gain. So you can't really look into these in a study in the United States. Allocation priority. If I have a family member that needs an organ, if I put myself on a list as an organ donor, what if they go higher up the list so they're more likely to get an organ? Israel has been doing this since 2008. And what they found was about, the way that their system works is the family has to approve before deceased donorship. They saw that there was a 55% authorization by family in these cases after the enactment of the allocation priority policy, as opposed to 45% beforehand. So it looks like it has made a difference in that case. The idea of opt-in versus opt-out. The United States is an opt-in country, meaning that when you go to the DMV on your driver's license, you say, yes, I'd like to be an organ donor. That's not the case in every country. Some countries you have to specifically say you do not want to be an organ donor. So there was a good study that looked at 48 countries over 13 years. What they found was that overall, you see more donation in countries that are opt-out, meaning you have to specifically say, I don't want to be an organ donor, than opt-in. But something that's interesting and maybe an issue for us going forward is the countries that changed from opt-in to opt-out actually saw a significant drop in their number of donations in the years afterwards, thought to be related to some worry about the government or medical practice and distrust there. All right. Immunosuppression, very briefly, we talked about tolerance. More likely to be observed in liver. There's only been about 100 total cases in kidney transplants that have exhibited tolerance since the 1970s. The idea of induced tolerance, how can we actually affect that change? Everything we've seen at this point has been spontaneous tolerance, spontaneously not rejecting an organ. We've not actually been able to induce tolerance, but there's a lot of work being done on this. Problem is we have no idea what the true mechanism is, so there's going to be a lot done with this in the future, hopefully. Xenotransplantation. Swine model has generally been used due to the similar organ size, short gestation of pigs, and large litter. So you have, if you had a clone group to work with, you can certainly get the numbers you need to have a program. There's a lot of obstacles. Physiological, their optimal temperature of their organs is different. Perfusion pressures are a little bit different. Microbiological, there are numerous swine diseases which can infect human beings. And immunological. We actually have been able, there's pig labs out of Mass General and also UAB. There used to be one at University of Indiana at Indianapolis, but it sounds like that one's not going to be doing as much anymore, where they're actually knocking out certain characteristics using knockout genes on pigs to prevent hyperacute rejection. But we haven't really made a whole lot of progress in cell-mediated responses at this time. We've actually been able to, this is out of Mass General, they actually spliced in human coag factors into their swine line to see if that would help, and then used a pig to baboon model. And they found that at 25 days, there was no macroscopic necrosis of these livers. There was no vascular thrombosis. They did have some duct necrosis, which is certainly an improvement in terms of rejection and survival and overall quality of the organ after this amount of time than they'd seen before. So as we go forward and we're better with this sort of thing and manipulating these swine models, I think we're going to see this as a viable option, maybe not necessarily right away for giving a pig liver to a patient and having them work, but as a bridge to them being able to get a human transplantation. And down at UAB, using, again, we talked about this knockout to stop hyperacute rejection, they've actually gotten out to 125 days of kidney function. So I think this is certainly a direction we're going to be going, but at the same time, if this talk was being given in 1980, they would have a segment on xenotransplantation and how we're very close to having it happen, and it just really hasn't gotten there yet. And finally, last thing, organ engineering. We can grow tissues. We can grow liver tissue, we can grow bile tissue or bile duct tissue, but we can't make organs yet. So there's been some work that's been done on how to actually fabricate organs. We live in a world now that has 3D printing, has some just amazing materials that really can hold up in physiological states. Are these options for creating organs? There's been some discussion of using 3D printing to create a scaffold of a liver, and then actually taking the recipient's own liver tissue, growing the tissue on that scaffolding, doing the same thing with the bile ducts and all those other tissues. The problem is we don't really understand the physiochemical signaling that makes all of these tissues work together as a functioning organ. And until we can make those breakthroughs, we're going to have some difficulty, but we are working on that as we speak. So this may be the end game for actually solving the transplant issue, being able to regenerate your own organ. But we're really nowhere near that at this time. So in summary, there's a great need for organ transplantation. I think it's going to continue to grow in the future. There's a great potential here for improving the duration and quality of our patients' lives. It's going to be a very rewarding career. There's a great possibility for reduction of healthcare costs, but we're going to require an awful lot of innovation, funding, and work to advance this. And unfortunately, there are a lot of ethical dilemmas which are there that have been debated hotly, and we still don't really have great answers to. So that's going to be a field going forward that we have to worry about. Thank you very much. Any questions?
So that allocation priority thing, I think I heard the way it works in Iran is you want your family member to get an organ, then you have to get an organ.
They trialed that out, and that part actually didn't work all that well, and they backed off that somewhat. At least that's the information that I was able to find, because they did try two strategies. They tried the paying for organs, and then they tried the bumping up the list part. The bumping up the list part for allocation wasn't as successful as the financial incentives that they gave. So the first real, and actually it's right up at the beginning, but I had so much history junk that I backed off of it. The first artificial kidney was attempted as early as 1913, which was really kind of an attempt at hemodialysis. And it was as early as the 1950s or 1944 was actually the first viable hemodialysis. How did that play into transplant? It seems as if it kind of ran parallel to. Transplant was something that was certainly being looked into beforehand, but then now in the 1940s, you've got a viable option for keeping people alive. There was actually even specific... the recipient list went up because there were more people surviving, and it's interesting. Our country is one of the countries, not the only one, but one of the countries that uses hemodialysis as a way of life. Whereas there are other countries in Europe and elsewhere where hemodialysis is generally only instituted when it's a stopgap to a definitive treatment, meaning we think this is acute kidney injury and you'll be able to get by it. Those countries tend to be much more aggressive about obtaining organs because the idea also is that you're only going to go on dialysis if you have the ability to get a transplant. So in the United States, if you have type O blood type and you're not going to be getting a transplant for 7 years, obviously hemodialysis is how you're going to be living. Whereas in some of these other countries where hemodialysis is used only as a stopgap to transplantation or definitive treatment, they tend to be the countries that have some financial incentives for donorship. They tend to be the countries that have opt-out policies as opposed to opt-in policies to try to increase overall donorship. Because they don't treat hemodialysis as a way of life. They treat it as a bridge to treatment. But in the United States, certainly, and we have the highest kidney donor waiting list in the world. And it is because we actually do such a good job with hemodialysis and how they do. Michael? Yeah, I believe that NASH is really going to, over the next 10, 15 years, become the number one indication for transplantation, not only because of Hep C being hopefully kept in check, but also because we see what's happening with our population in terms of obesity and things like that. So I think that really is going to be a future area of growth. And unfortunately, patients that have high BMIs have worse outcomes than patients that don't. So in terms of developing new strategies to deal with folks that are obese and require a liver transplantation, that's something that's going to be happening as well. Out of Mayo and Rochester, they're now doing concomitant sleeves and livers to try to improve outcomes that way. But that's addressing the obesity at the time of transplantation. At Lourdes, they have tried out doing sleeves a year or two prior to renal transplantation because the surgeries themselves are less technically difficult when you have somebody of a more appropriate BMI. But I haven't seen a whole lot of studies that looked at what those outcomes end up being. But yeah, I think NASH is going to be a huge thing in the future of transplantation. Yeah, I don't read on those things. Yeah, I haven't really looked into the head transplant. There have been a lot of interesting things where they do these novel transplantations and stuff like that. The first guy that they actually did a arm or hand transplant on, interestingly, it worked, it didn't get rejected, didn't have a whole lot of function, and he actually had some docs at a different hospital take it off a few years later because he felt like it wasn't his. You know, we also, seriously, it's what he said. We've all seen some things on, like, you know, the face transplant. She did all right for a little bit, but it did reject. The interesting thing about those sorts of things is that's a lot more complex, I think, than just, you know, not just, but than doing a liver where you're putting together a couple of blood vessels and a duct and this. So I think those are great things in terms of developing techniques and seeing what can be done to make them work better. But most times those are very, very novel things. But I will be watching for the head. Thank you.